Good morning, everyone. So I need to ask you a few questions first. I'm not a normal presenter, so I'm going to ask that you participate in this presentation. Do you think you can do that for me? Okay, very good. So just a little bit about myself. I have no conflicts of interest to disclose. However, I have not had a very formal. He's right here. They'll take care of it. So I've not had a real straight path getting into informatics. I started in surgery. I was there for a while and said, hey, I want to move. I became a traveler. On my 5th day of my travel assignment, the nurses walked out on strike. I learned very quickly that things aren't always going to turn out the way you thought that they would. So for me, things changed very quickly. I became the most experienced nurse in the OR that day, and I was the only one that the surge techs were not kicking buckets at. So we had some very hard feelings against those nurses that came in to help take care of patients. I then took on their educator position. Didn't like my boss. They always say you don't quit a job for a boss. I totally quit that boss. So then I moved back to my hometown, and I joined the open heart team. And guess what? They were going to implement Cerner. I'd used Cerner before, and I loved it. So I was chosen to be the super user, and that's kind of what started my career in informatics. So today we're going to go over why I think the OR principles transfer to informatics. Also, what our DNA is and why that is helpful. And I want to understand the impact of the OR competencies in other areas of nursing, because I think we get siloed and think the only thing we can do is OR. Maybe that's because we what we love, but maybe we're getting a little burned out, as was discussed in other presentations. Maybe we need a change. So I think nursing has lots of options for you. So, but first, I told you I wasn't going to be a normal presenter. So first, we're going to watch a little video, and it just demonstrates what it looks like sometimes when you talk to those IT folks. No offense. As he's working on fixing stuff. And we did have a little issue, so it doesn't look exactly like I wanted it to. So if you could exercise some grace with me, that'd be greatly appreciated. So we're going to see if this wants to work for us.
I know that my father here is
So, are we feeling like this is what it's like to be top guys? Maybe other teams will go in that. All right, so, I gotta stop this, sorry. So, yes, it's very, very difficult sometimes when we talk to our friends in IT. Can you hear me? Okay. Sorry. So some other things that illustrates is, how long do you think that was? Any guesses? What? Huh? Oh, did it? What did it say? Very good. Have you ever said to somebody, I don't have time to call those IT folks? Because that would be the average length of a call, right? So we're going to go over what informatics is in my world. Now, I think there are lots of different variations in informatics. And in my setting, we do a lot of at the elbow with the people who are doing the work. We are very much in our clinical settings. I work in a facility that has 3 hospitals, 75 to 90 ambulatory clinics, 3 ERs, and 2 urgent cares. So we have lots of different clinical settings that we're working in. My team is made up of lots of different informaticists. We have nursing informaticists. So some people do have their nursing degrees. I also have some who, I don't currently have any, but I did have some that were clinical informaticists who had a clinical background at some point, but it might not have been a nursing degree. So I had some that were respiratory therapists, I've had paramedics, just different people who are interested in informatics and helping out their colleagues. We have a we have a physician on our team who has a loose association. He's our clinical chief medical information officer, which our organization is like in the process of transitioning out, but he still provides a great deal of resources for us as he can test things from the physician aspect, especially in our current project. We're bringing up the electronic prescribing of narcotics, so EPCS. I also have some healthcare informaticists who, I have 2 ladies that just joined my team who have bachelor's degrees in informatics, but they have no clinical experience. So our team is quite diverse, and so far it's working. I'll tell you next year how we're doing, as I walked into a crazy situation and we are all, everyone except me is brand new, so we are working. But a little trivia, if you went to the presentation yesterday on informatics, the information was on the slide, so you can't answer. What year did the American Nurses Association designate clinical informatics or nursing informatics as a nursing specialty? Anyone? Okay, you said you were going to participate. She's close. She's close. Did anyone hear? What? Oh, good job. Okay, you ready? Oh my gosh. She's crazy. Watch out. Protect your water. All right. So they documented the first scope of nursing informatics practice in what year? That was also in the presentation. Don't look at your notes. Don't answer. When was the first scope of practice documented for nursing informatics? What year? Anybody? Anybody? Nope. After we made it a specialty. Quite a ways after. Closer. How about 2008? Very good. All right. So simply put, what is nursing informatics? It's a combination of nursing science, information science, and computer science. When I'm asked what I do, I just say I'm a nerd nurse. It's a lot easier for people to understand. If they have specific questions, I go into it, but really, I'm a nerd nurse. I'm also the translator. So instead of having that 8-minute conversation with that IT person on the phone, most of the people at our hospital will call our team and say, hey, I got this issue, what do I need to do? Sometimes the answer is, yeah, you need to call the help desk and get some help from IT. It might not be something you can fix. A lot of the time though, it is more of a process issue. So our group is focused a lot on process improvement. We've had our electronic health record for 12 years, so we're quite stable. We are doing upgrades constantly. We're a large organization, so we have a good relationship with our EMR vendor, who happens to be one of the big dogs. And so we actually do get to see changes being made, which is nice. We have an enterprise contract, so we don't get nickel and dimed for those little changes. So that's nice. So we use our skills in nursing to harness what we need to document so that when you come to me and say, hey, I want to build that portfolio we talked about in the last session, we can help you with getting you the information you need, your case logs, your, what am I saying I do every single case? What are my nursing diagnoses that I'm saying we did achieve? What are my outcomes? What are we going on? I can provide that for you. I also, on our team, we do a lot of educating. We are the place where all the physicians come in through and get their one-on-one training. We set up their preferences for our Cerner stuff. We help them understand what they need to do and why they need to do things. So all of our surgeons, hey, you're going to need to put in orders. There's no question. There's been so many people have told me, yep, we can't get our surgeons to put in orders. The only thing I can tell you, you got to hold those feet to the fire and you got to have leadership that's willing to do it. We had issues for a long time until our OR director stepped in and said, okay, we have this OR and surgeon dyad leading. So the surgeon and the OR director went to those surgeons and said, guess what? Your orders aren't in, we're canceling your case. Your orders are not in for pre-op, we're not going to screen your patient. We're not going to do the pre-anesthesia screening, right? Yeah, it takes guts, it takes involvement, but guess what? They didn't even know that we were having issues because what do nurses do? We just get it done, right? They didn't know. So it was partly our fault as nurses. We didn't tell them that we were having issues. They just said, oh, well, I know how to do it. I know what they want. I'll take care of it. But then we didn't have any data to support that they needed help, right? So how does the OR make us better for informatics? I would say, do you all agree that we have attention to detail? How many times have you seen a colleague walking down the hallway, their back is to you, they're in scrubs, hat, all the good stuff, you know, and you know who it is just by how they're walking. People don't understand that. That's not normal. Just so you're clear, that's not how normal people know people. And I know we've all heard the, oh, you look different in clothes comment, right? We also have a great way to communicate with others, right? How many times have you had to tell someone something with just your eyes, right? We have to be aware of our surroundings because that patient is our main focus. We know when we can talk. We know when we have to be quiet. We know when to back off on our questioning, and we know when to question. I think one other thing that I find in those of us who have specialty type nursing, specifically the OB nurses, the ICU nurses, OR nurses, we have to be fearless. All nurses have to be fearless, but I think we are fearless to a different extent in that I know you're just a surgeon. Sorry, I still need information from you. I'm still here to help you. We're all on the same page, but if you're doing something I don't agree with, what's my responsibility as a nurse? I need to stand up and say something, right? And I think that's just some of the things that make us great for informatics.
So I told you I'm not going to be normal. Here it is. All right. So first of all, if you have drinks, protect them, please, because it's going to get fun. You guys need to wake up. This is not really working for me, and it is all about me today. So, have any of you ever heard of Mad Libs? Okay, so just because I know when we first started doing these, I have a 10-year-old daughter, and she I gave her a Mad Lib thing, and she didn't use it, and she found it one day and was like, oh, we can do this. So we do this almost every night. And I said, oh, that'd be a great way, because I think context helps us a lot. Why do we have trouble talking to IT? They don't understand our world, right? So I'm going to have you fill in my little story. But all I'm going to ask for is like an adjective. What's an adjective? You can cheat, but you have to talk. Someone, what's an adjective? A descriptive word. Very good. What's a verb? Action. And a noun. See, I should have done the Schoolhouse Rock, right? And then you would have had another. Oh my goodness, she's crazy. All right. So I'll give you the prizes afterwards, since there aren't many of you and I don't want to hit you because I'm not a good aim. All right. So somebody give me a date. What? Okay. And a body part. Liver. Number. Oh my. Disease. A body part. I heard arm first. Number. Oh, that would work in this situation. Disease. Oh my goodness. All right. Number. Noun. Hooker? She's in Vegas, right? I mean, come on. I did say I didn't want this to be the traditional talk, right? I better. Verb ending in ing. What? What? Shopping? A direction. Body part. Neck. Adjective. Okay. Noun. Direction. Body part. And a noun. What? All right. So would you like to know what you just filled in? It was an off note. Good job. So this is a cabbage off note that one of my surgeons allowed me to use. So our date of the procedure was November 11th. We had liver artery disease. It was class 27 angina. Cirrhosis with esophageal reflux disease, ulcerative colitis. Our preoperative or our postoperative diagnosis was arm artery disease, class 3 angina, gonorrhea, gastroesophageal reflux disease, and ulcerative colitis. So I don't really know how we gave them gonorrhea during the procedure, but just saying. Our operation performed was a 11 Hooker coronary artery bypass. We went shopping using south internal neck artery of the soft left anterior descending coronary with reverse saphenous Las Vegas arterial coronary grafting to the first diagonal coronary with north radial eye pedicle. Florence from the foot of the diagonal saphenous vein graft to the obtuse marginal coronary artery with reverse saphenous vein arterial coronary graft to the distal right coronary artery. So I appreciate all your help, but just so we're clear, might it have been easier if I gave you a little help with what words I might have wanted? Okay, so more data helps us, right? Clinical informatics focuses on the data. We focus on pulling data, running data, helping you get data into the patient's record, which, you know, with electronic health records, it's gotten a lot easier. Or so we say. Some people would argue that point. So here's what was originally in there. Of course, we don't have class, 27 angina? I haven't seen that, thank goodness. So just to give you a little overview of what we were kind of looking for. So what was this used to illustrate? Well, it's what your world could look like without the informatics specialist. There's no understanding, you're not on the same page, you don't know how to get across to them what you want to say. So during that, I was gonna pass out my prizes, but I didn't want to hurt any of you. So please take more than one, because I don't want to take any of this home. So there's erasers, beach balls, little squishy balls, and we'll just pass it around while we do the rest of the talk. So as you can see, if we have the context, and in our case, the experience, we're able to communicate with those clinicians in a whole different world. I'm able to say, show me what you do and what you're looking for, and then we can approach the issue and find out how best to resolve it. I want to make sure that you get what you need to take care of that patient in the least obtrusive way. I don't want you to have to think about, where do I have to put this? What rabbit hole do I have to go down in our electronic health record to get the information to show that I provided the best nursing care possible, right? We want to make it easy. That's my goal. Because I don't want you talking to Abbott and Costello for 8 minutes when you're trying to figure out what you did. As we know, if we're doing a case, we have tools that help us, right? We have things that give us the background. We have a provider's preference card, right? That helps a lot. We're able to see what's going on. If the provider sews left-handed, right-handed, we know, and we're gonna set their sutures that way. If they only want to be called by their first name, as difficult as it is, we will try, I will try, I really struggle with that one. I will try to call them by their first name. The more you know, the better job you can do. In informatics, I'm here to serve you, I'm here to make your life easier, and I want to provide a service to you so that you can focus on taking care of the patient. As an OR nurse, I know that I need to pay attention to every single thing you tell me that you're looking for. I need to ask those inquisitive questions so that you can have the best outcome possible and you can get what you need. If you know the basics and the context of the information you're looking for, I'm going to ask you questions to clarify. I'm going to bring in a little bit of experience to say, hey, what about this? Does this work better? You've said, I can't find X, Y, and Z. Well, let me show you a quick trick to get there. We have lots of initiatives that come down that we have to do. Things that, you know, with our opioid crisis going on right now, our healthcare system is doing a nationwide implementation that we are all going to use the same documentation tools for opioids. We want to make sure that we are sedating our patients appropriately. Well, guess what? I don't want to just slap those into our electronic health record in a place that doesn't work. I don't want to make all the OR nurses document something when you're not the ones monitoring it. I'm going to say, well, for OR, that probably doesn't make sense. Let's ask them what they need and where they need it. So we get in there and we have those conversations. We want to make it easy. I know sometimes you think all those IT people and
those informatics people, if you even have them. They just don't want to do anything. They don't want to help us. We do want to help you. We want to make your job the best it can be. And we want to ease that pressure. I know change is hard. Well, guess what? My team likes change. So yes, we are a little crazy. We're a little unconventional, and we like to have fun because we feel like we bring something to offer that can make your life a little bit easier. So we all know that if I gave you a scenario to fill in and say it was how you bring your patient back to the room, we're going to play one more Mad Lib, but this time I'm going to give you all the context. And this is to help illustrate why informatics nursing is amazing, in that I can come in and you can show me what you're doing, and then we're going to craft a solution that works better for you. So if you look at this, what should the first blank say? There's no right answer. Patient in time. 1207. Hi, what's my name? Good job. I'm your nurse today. I need you to sit up so I can untie your gown before you move over to the OR table. Next, we'll have you feel the sides of the bed, table, and make sure you're in the center. This is our anesthesia provider. Okay. And she will be taking care of you today. It makes it a lot easier when I can clearly see what's going on, right? And I think that's why I have loved this job, is I get to learn all those different things about nursing that maybe I haven't experienced. I came right out of nursing school and I went right into the OR. I lived behind those doors. I didn't see any other type of nursing. I never experienced that floor nursing. ER nursing, none of that. I didn't have that experience. But now I'm getting it. But as an informaticist, I'm going out and I'm validating, hey, what's going on? What do you really do? What do you do from day to day? You may say one thing, but what you're actually doing might be totally different. And what you're documenting you did, yet again, might be totally different from what you're actually doing. So it's our job to make sure that you're able to clearly document, clearly do, and in our world, we also focus on that process improvement. So if you have an issue, it might not be an IT solution, but that doesn't mean we can't help you. We also are trained in our world in performance improvement. So we look at that process as a whole. If something continues to happen, you know, admittedly, I don't want to say this, but we recently had 2 fires in our OR. Guess what? 2 fires means you've got a process problem, because it's not something that happens. That's a never event, right? So there's a process issue. Is the electronic health record going to fix that? No, we have a fire assessment in our OR charting. Guess what? It's not working. So we need to fix that process so that we can protect those patients. So as I said, we have that attention to detail, and we identify, so I already gave you this one. You know, we can identify those people, we can identify details. How many times has a provider asked for something and it's already in your hand and you're giving it to the field? Or if you're scrubbed, you're passing it to them before they say it. I mean, when you're scrubbing an open heart, it's a good sign that I'm just handing you stuff. We're talking about something else. I'm handing you what you need as you need it. We're not having a discussion. We're having a discussion probably about what we're doing this weekend, and we're doing the case. We're focused on that patient, but it's a dance. We're so ingrained. We know how that works. And that's how I see our role in informatics is we have to help you see from the outside what you're doing in the OR so that it can translate back into the data, the processes, those other things we need to do to accomplish our work. And as we know, OR nurses especially, I think all nurses, but who do you put first every single day? Your patient always comes first. And then we're there to serve who? The doc, right? And what comes last? Ourselves. So one thing that informatics has done for me is it has allowed me time to grow and to mature and change and to meet the needs of my family. I loved the OR and I loved Open Heart. However, handing my screaming child off to my mom in the middle of the street because I got called back in and my husband worked retail, that was the straw. I couldn't take it. I needed to move on. I needed to find something that provided balance for me. I also found that I have had so many opportunities to grow and learn other things that it has just fed my soul, and I'm able to focus on myself, on those around me, and the clinicians at the bedside in a whole different way than when I was their peer and their colleague and working side by side with them. Now I see them in the hallway and they say hi, hey, how's it going? I can really ask them and have those conversations in the hallway. And they say, you know what, that really meant a lot because I know you understand and you really care. So you're providing that care for those who are at the bedside. And though it's not a formal job of my role, I think it is because we are all there to support each other. Because if you're having a bad day and somebody smiles at you in the hallway, that can be enough to turn your day around, right? And because I have balance and true joy every day that I go to work, even in the most stressful times, I'm like, oh, my mantra, my boss always makes fun of me because she's now using my mantra. Because in the OR, what happens? Our patients' lives really are on the line. In informatics, guess what? No one's dying. And it's not gonna matter in 5 years. So that's my mantra. No one's dying, it's not gonna matter in 5 years. So for me, informatics is a whole lot less stressful. Just so we are clear, we know that you can do any case, anytime, right? What do you need to do a case? A knife, bovie, suction. I'm good. Everything else comes next. If we get a trauma, I can do it. Yeah, I'd prefer to do everything I'm supposed to, but if my patient's life's on the line, I'm gonna do what it takes. Informatics is a controlled chaos in the same way. We have different people coming at us, regulatory bodies, people who think that they need their thing fixed. Dr. So-and-so wants to have this dictation just come in automatically. Yeah, no, it can't happen. Oh, they want you to do their orders for them. Nope, not gonna happen. But we know that you can do a lot of things and it's up to you to make your career whatever you want it to be. We listen, we understand, we pay attention to details as we've gone over multiple times. We also have to be knowledgeable about the standards, and we all know we follow a standard, right? We have AORN standards. We use sterile technique. My favorite time in informatics was when I got to teach our SurgeonNet module to our new RNs. We had 4 new RNs who came in and they're like, oh my goodness, the person who used to teach SurgeonNet's gone. And I said, guess what? I've used it, I'm good. I can teach it. So I went in, and one of the gentlemen in the class had been a tech in the ED, and he then went on to nursing school, worked in the OR or in the ER at a place, and then he transferred to the OR. And he goes, you know what? There's one thing I've learned in the OR. We really thought in the ER that we had that sterile technique down. We are so screwed up in the ER. We don't even understand what sterile technique is. I said, yep, and don't tell me cath lab's got to be there, because that, not happening. So that was just one of the fun opportunities I had when I got to teach the class. We also need to know our clinical context in every realm. Like I said, I am an OR nurse, so if they want me to look at something in the OR, fine, no problem. It's when I have to go to those other areas that I'm not experienced in that I'm a little scared. I also worked in ambulatory, so that was no problem for me, but take me to the urgent care? Yeah, I don't get that. I don't get what you're doing there, but we get through it. I can ask enough questions to get things done. Workflow is really big for us because in our areas, like everyone says they're special and that they do something different. Guess what? They don't. You might think you do, but you don't. A case is a case, a patient's a patient. You might be documenting it differently, but is that maybe not the easiest way? Shouldn't we do it the easiest, most complete way possible? That's why I'm gonna look at your workflow and I'm gonna help you figure out how to do it better. It might be that you've got the best way and we need to tell everybody else about it, but we're gonna spread that word and try to make it standard. Of course, you need confidence. My staff said, you're doing what? You're doing what? You're going to speak at a conference? I said, yeah, I've never really done it, but I'm gonna try. I won't know if I can do it unless I try. So please, feedback. I can do it better, I know. So I can take criticism, please. Because the difference between feedback and criticism is how you respond to it, just so we're clear. So I'm gonna take it as feedback. Some other reasons I think that go unnoticed in the OR is, while I don't want you to necessarily be tough, I want you to have thick skin. I want you to know that the way people react to you is not necessarily about you. It's pretty much always about them. And I think that's something that we as OR nurses know, that surgeon yelled at me. It didn't feel very good, but he yelled at me because the patient was at risk, or he was nervous, or he was new and he didn't have enough experience. So he was looking to me, the experienced scrub nurse, to tell him what to do. You know, how many times has that happened, right? We can speak clearly. We understand our surroundings. We are emotionally intelligent, though we think sometimes we all have opportunities to do a little bit better. But we know that if we're having a bad day, everyone else is going to see it, right? And of course, you are always focused on your patient. So the same is with informatics. We've already gone over why the OR is a specialty. We know that. So for me, it just translated into a different line of work. I now have a larger audience and I have a larger scope of practice. I cannot tell you how many times I've been told, oh, well, when you were a nurse. No, I'm still a nurse. I'm a nurse every day, and I take care of a lot more patients now, because what I do impacts how our health ministry is run. It's a Catholic organization, so we call it ministry versus system, or whatever else you might call it. I've been there for 12 years, so that's how my brain works now. I have a larger scope of practice. I now am at the table telling everyone, oh, well, we need to protect our nurses. We need to do this, or we need to not do this. And I feel like we need more nurses at those tables with those C-suite people, those people who are making those decisions that impact us. We do bring in a lot of money in the OR, and it costs a lot of money to train new nurses. So shouldn't we retain as many as we can? Shouldn't we make our patients have the best outcomes possible? Well, how do we do that? We make sure that people are trained appropriately. And if they're not, we invite them to take a position elsewhere, right? And sometimes the data can support that. So I have a bigger opportunity here. I'm always learning, and of course, I'm always a nurse. I've also said that a picture is worth 1,000 words, right? Sorry, I like videos. So you get one more video. This one, he's gonna tell a story, and he thinks he's right. So we'll see what you think. Oh, this isn't the right video. Let's try this again. No, I don't want that one. Top. I want this next video. Oh, we didn't get the right video. Okay, so basically the video that was supposed to be here, nope, was one about where he basically, they tell him, you didn't pay rent for 7 weeks. And he's like, well, you know, okay, here's your $27. $27? 7 weeks, rent's $13 a week. That's not the right answer. Well, the way he does math, he counts out, he writes 13 7 times, no, it's 39. I don't know what his total is. But anyways, he writes out 13 multiple different times. He adds up all the threes, and then instead of adding the tens in the tens place, he goes 3, 6, 9, so 21. And then he adds all the ones and adds them together. So it's all about the picture, but he's able to prove that his math is right. And so his rent is a whole lot less. And the guy's like, no, that's not how it works. Yes, it is. See, I can tell you. Well, let me do it. Yep. So he has him add up the threes, and then he continues, go 1, 2, 3, 4, 5. No one adds those on. So we need to make sure we have the right picture. And That's why it's important that we have those interactions. I don't just take your word for what you're doing. I'm gonna come and have that side-by-side conversation with you. And then we're gonna draw it out on paper.
And it may look something like this when we get there,
because we might not know what we're doing. Case in point is this next slide, where this was our OR charges from the time the patient was scheduled through the time the bill dropped. Okay? All those yellow boxes are places that our charges were getting hung up. We had $3 million almost all the time on hold because we couldn't get things processed through. We had switched over to a utilization system that was nationwide for all of our Ascension facilities, and they didn't add all of our products. So when I billed for it in the OR, there was no charge associated with it. So then it went in this little queue and somebody worked that. But there was only one person who could add charges. And it might take them 10 days. And then, oh, by that time, we hadn't checked through the documentation. Well, then that nurse that needed to fix the documentation, she was gone for 2 weeks. I mean, we're almost at a month. Well, of course we have millions of dollars on hold. I mean, how much is a total? How much are you going to bill for a total? And if they did their whole room and they used that implant every single time and we can't charge for it, we've got issues. Once we were able to identify this, we were able then to say, okay, well, what else could we do with that chart? Well, part of it's waiting for something else. Our processes were not all electronic. We're not there yet. I dare say that we've made more paper in going electronic. Another story completely. But don't tell the doctor that we recently brought up on our electronic health record. He thought it was really funny. He goes, girls, just so you know, they're coming in, we're doing electronic charting, and I think they've taken all the paper out of the office. So if you need toilet paper, my trunk is full of toilet paper. We are good to go. If you need toilet paper, you just let me know. But that, of course, as we all know, I think we've created more paper going electronic than we've gotten rid of. So I think OR nursing is a wonderful specialty, and it prepares you for lots of other areas of nursing. And just a reminder, there is life outside those OR doors. Nursing always will go beyond the bedside, and process improvement is definitely important. But the biggest thing is we can't do this alone. We need to have each other. We need to communicate. And as much as we can go electronic, no one ever said you can't talk. So you better still communicate with people in different ways and the way that they need to hear things. With that, any questions? Yes.
When you go, is it like a 2-year program?
So,
and then you get.
So I personally have my master's in informatics. So I took a 2-year master's program. I did Walden University online, and the first year was focused on just general master's preparation. And then I had a year focused on informatics. And at the end of that, I did a practicum. My practicum was with a nurse of my choosing. Since it was an online course, I had to find my instructor that I was going to care with. And she happened to be a nurse who had a master's. Hers was not in informatics, but she was in the IT role. So my project was bringing up our MERGE software in our cardiovascular lab. So our cath lab patients, every time they document, it goes into a different system that's then interfaced with our electronic health record. So yes, it was a 2-year program. It was online. Not all my staff have that training. And I personally feel like you don't have to have a formal education because nursing knows how to do informatics and just never called that, right? You've done it. You've said, hey, I want to do X, Y, and Z, let's make it better, right? This doesn't look right, let's change it. It's all those things that we do naturally that I can't say that having that extra education makes it that much better. I do think it gives me credibility across the continuum, but to do my everyday work, I don't necessarily.
You don't need like software training and
I don't do any back end builds. I do the interface between those IT folks and the clinician. So my informatics world is that translator between the two. I don't do any of the back end, and if I do, we have with our EPTS, electronic prescribing narcotics, there is a portion that we might have to go in the back end, but that's what I say, haven't done it, you're gonna have to teach me. And, oh, yeah, that's easy enough, we can do that. I do testing, so when we change things, like our immediate post-op note, we had a joint mission survey, and they're like, hey, your timeout's not documented when you do cases, in the units. And I'm like, well, they have this form that we're supposed to do, that's what we do everywhere else, we got an hour and surgeon. So they don't have surgeon. Okay, can we add it to the immediate post-op? I guess you can, but 80% of our surgeries are done in the OR, procedures are done in the OR, and they're not. So I don't want that conflicting information or dual documentation. So my job is to figure out how can I make it pull from one place to the other, so that if it's a surgical procedure, it doesn't have to be that. So that's going up on the 22nd.
I think one of the other things you share with us is if somebody's interested in getting to that, one way to get it diagnosed there is to volunteer to be supervised.
Yeah.
And that way, I mean, really like doing that, so that would be kind of segue.
Yeah, totally. And that's how I recently hired my cellular rock star informatics nurse. She started at the end of March, and she has already taken everything and running with it. She was an ICU nurse who said, hey, I really like this electronic thing. And she applied for the job. She said, I didn't think you were even interviewing. And I said, why not? And she goes, well, all I had was supervisor. I said, yeah, you did. And I interviewed her. She could talk through the passion of understanding what it was. And then she said, oh, we talked about the portfolio in the last session. She said, hey, I got some things that I made for our nurses, checklists of how to make sure that they did the right thing. And she was like, oh, those checklists, I'll send them to you. So they were able to see her work. And so it was a great transition. Yeah, you've got the passion, you know what you're doing, and you're very teachable, and you want to learn. And I think those are the things. What can I do better? Not make these two go to they must have partied too hard.
Sleepless nights come up.
See, I was fortunate, I was not on the party today. All right, thank you, everyone.
And please make sure, yep, perfect, evals. I'm afraid to touch anything. Yeah.
I'm in a small service center, so I still under.
Uh-huh.
How can I go into this, to get into going to like classes and stuff?
So do you have a master's degree? Do you have a bachelor's degree?
Bachelor.
Okay. Are you interested in a master's
Yeah.
degree?
Oh, no.
Why not?
I think I'm done studying.
Okay.
Does it have to be?
No, it doesn't have to be, but I think because you're not going to have experience in like project management and
Got it.
stuff,
Okay.
like if you look at to get the certification in informatics, it requires experience.
Okay.
So
Gotcha.
if you're interested in informatics, I would say if you're not interested in moving jobs, the master's would be the way to go.
Oof.
It's really not that bad. All they're trying to do is change how you think,
Yeah.
and it's a lot of paper writing is all.
Yeah, that's the thing. The paper writing. When you said paper writing, I was like, oh,
Is that? It's really not that bad. It's not bad at all. Like I thought it was. Yeah.
after the last grade of my practice, I want to respond. I know that. And there's an extra, medium word together, just better picture. Okay, what was this? Yeah. What did they say?
Yeah.
What did she said? She gave me a plan of what you want to work on for your gymnastics.
So how are you gonna use the data or the electronic records to fix problems?
I think I had no clue.
Okay.
I had no clue.
Okay.
I didn't have any problems. I haven't worked in before. It's 25, or 29, or 12, when I was a chaplain or something. I've been working in the private industry.
Oh, okay. So how do you track this? How do you track?
I never did. No, I didn't know I was supposed to.
No, but could you make a system to track contact hours? Would that be something that you could go with on, like, informatics project that way? Is she looking for a project for you?
She was. I'm going to be taking this next summer. But I had no questions about anything. I'm here to learn what you guys teach. And she's saying, well, here, tell me what you want to work on for the summer. And I had found it in matters there's that would mentor me, but I had major scoping and trauma. And, you know, I had to wait these 2 months as everything recovered.
Yeah.
So I drop out in good standing.
Yeah.
However, I will be thinking about next summer, but I still don't have a clue.
Well, so I would personally do projects the way we are integrating the electronic.
I was gonna wait until my mentor could do something she wanted.
Well, and that's what you need to have that conversation with her.
Okay.
What are you working on? What project can I be part of?
Okay.
So like for us, we recently did about people to arrive. So all of our students are that position change. So that would have been a project. That's what my student this semester is working on.
Oh, so those are the questions.
Yeah.
Yeah. See, right now I'm actively looking for a job because I had to do field work hours for the summer, and that's what I was going to be driving. Yeah, I was going to be driving 2.5 hours to this small hospital.
Yeah.
Because my school had to have an affiliation agreement.
Yeah.
So the Department of Providence Healthcare said fine.
Yeah.
And this nurse was willing to
Yeah.
take me as a master's student for this 120 hours. Yeah. But now I'm looking at the spring. Yeah, I'm going to have to do 240 hours for, along with my capstone.
Right.
I have no idea what that's going to look like, what it's going to be. There's nothing more desire in it and allow me to do this research, but I have to get a job now into an institution where I can do this.
Well, we don't have to.
But we have to have access to patients.
Yeah.
Or some nurses or someone.
Yeah.
You know what I mean? I'm just hoping these things will fall into place and I'll know in time through. That's all we do. I haven't read any other room.
Well, my presentation wasn't loading, so I had to run down and get to the lobby, so.